Pleasure to be up here. My talks are geared towards themes, and hopefully I can take you through the next couple hours through joint replacement in a codified fashion that what I would describe as put it all together. So this is what we're going to start off. Again, I'd like to thank Mark for having me here today. This is our first time in Denver. I think this is a much better lecture hall than what we had in Colorado Springs, so this is a really nice place. Start off with total hip replacement. Is this mic too loud? Are we okay? Is that okay? Okay. Total hip replacement, the traditional goals have been relief of pain, resumption of activities of daily living, and affording maintenance of independence. The active patient, the design issues have always been fixation, the articulating wear profile, and stability. Older patients do fine with whatever you put in them, cemented hips, non-cemented hips, but it's the younger active patients that we have been really running into problems and having hip failure. What we've been looking at is cement fixation, non-cement fixation, and I'll start off by talking about bone ingrowth fixation. Why bone ingrowth? It has to do with the fact that with younger patients, this is a Rancho Los Amigos Hospital study with Pierce Conity showing that at 16-year follow-up, there's an 82% failure rate of patients that are less than 45 years of age. If you look at this in the European literature, Mittelmeyer's, same thing, 66% failure rate in the younger active patients. What is the problem with the metal plastic bearing in the younger patients? It has to do with more cycles, more wear, more stress, and weak cement. And the basic formula for any joint replacement, whether it's hip, knee, or shoulders, that it is cycles times stress equals wear. Very analogous to the freeway where I drive to work. You can see on the left, that's the fast lane, where you have relatively low weight, low frequency, and low wear, as opposed to the right lane there, where you have high weight, high frequency, high wear, and you can see all the cracking of the cement. Notice green laser, different than the other guys. Should be an extra style point, okay, guys? Green laser. All right. I won't use it very much, but I just had to bring that out. Okay. If you look at cement fixation, it's static. It's a mechanical micro-interlock with the bone. It is prone to microfracture. Once it cracks, there's no remodeling, and it's one additional interface that can fail. So with younger active patients, we tend to shy away from the cement. Remember, for the test, cemented cups fail at a higher rate than cemented stems. The reason being is because of the shear and tension forces that's been in training and board exam. It's usually seen around 10 to 12 years, and that was described by Bill Harris and his group. Remember that stems are loaded in compression and tend to last longer. So cement resists compression better than tension, another in-training question that we saw. If you look at bone ingrowth, it's different. It's a biologic fixation. There's ongoing bone remodeling, and it's potentially life-lasting. So if you do have a microcrack in the system, the osteoblasts and osteoclasts will work on repairing that lesion. So the success is design and technique dependent. Depending on the amount of motion that implant sees, you can get either bone ingrowth, fibrous ingrowth, or if it's really toggling in there, it's fibrous encapsulation. The formula for bone ingrowth requires several factors to be working. You have to have optimum pore size, optimum pore depth, optimum porosity, minimal gaps, rigid fixation. I'll stress that you must have rigid fixation. You have to have minimal implant micromotion. You have to have basically cortical contact, which is stronger than cancellous bone, and you have to have normal bone metabolism. So if the bone cells aren't working and they're dead with radiation therapy, you're not going to have successful bone ingrowth. In fact, that was an in-training question last year. If you look at the optimum pore size, these two studies show that you want the pore size between 50 microns and 350 microns. Those pores on that bone are very similar to what you can see the pores there. So that's the rules for pore size. Also, pore depth is important. The deeper you go, the better it gets. The more pore depth, you get a stronger fixation. If you look at this study here, testing different sizes of pores, just showing here where the pore layers 1, 2, and 3, with each successive pore layer, you have stronger interface shear strength. So the deeper the bone interdigitates into the prosthesis, the stronger the implant fixation. Also as important is the surface area. And that's what we describe as porosity. If you have a large surface area, you're going to have more pores available for bone ingrowth. So if it's too porous, however, the porous coating will literally shear off the metal and fall off. So yeah, the optimum porosity is around 40 to 50%. So here's a study here showing if you increase the porosity from 30% up to 40 to 50%, you have increased shear strength and pull-out. And the maximum porosity is about 55% because after that, the porous surface becomes so weak that it literally will shear off. Roy Blebaum has shown that the gaps between the prosthesis and the bone have to be less than 50 microns. Bone cells will not jump gaps, so you have to keep those it keeps the gaps less than 50 microns. That's why it's technique dependent when you're broaching. I stress this, rigid fixation is required for bony ingrowth. You've got to minimize that micromotion. Pillar showed that the permissible displacements that would not inhibit bone formation was 28 microns, and you got 100% ingrowth. If you had motion greater than 150 microns, you got fibrous ingrowth. So you really got to wedge these implants in there tight, so the bone will go into those pores. So the bone cells can't see a moving target. So that's why non-cemented fixation tends to be a little bit more demanding than cement. Now, to achieve that initial rigid fixation, there are two techniques to do it. There's what we call the press-fit technique and line-to-line technique. So when you talk to your colleague and say, I put in a press-fit stem, it's not really putting in a press-fit stem. You're putting in a non-cemented stem, and the technique that you're using is a press-fit, or I'm using a line-to-line technique. The press-fit and hip is a technique, not a fixation method. What you really do is you ream the canal to a certain size, for example, 10 millimeters, and you insert a stem that's slightly larger, say, for example, 11 millimeters. Same thing on the cup. You ream to 50 millimeters on the cup, and you put in a 51 millimeter cup, and it's slightly larger in size. The theory being there is that you're wedging a large peg in a small hole, and once it's wedged in, you generate these compression hoop stresses, and those initial compression stresses hold that implant in place for your initial rigid fixation so that the bone cells will grow into the porous coating. So the compressive hoop stresses provide the initial rigid stability for the first 6 or 8 weeks. The long-term fixation is provided by the biologic microinterdigitation, and that's the long-term survival of the prosthesis. The potential complications of press-fit technique is fracture because you're wedging a large peg in a small hole. You can crack it. And the usual reason for fracture is under-reaming. That's an in-training and board question. The main reason for acetabular fracture in total hip is under-reaming. Remember that for the in-training, or for the boards. Now, in contrast, the other technique is line-to-line. And again, it is a technique. You ream the canal to a certain size, for example, 11 millimeters. You insert a stem of the same diameter. You put your AML stem, which is 11 millimeters. The prosthesis is generally extensively porous coated all the way to the tip. So this extensive porous coating will provide an initial interference fit. Other people call it a scratch fit, as we would say. And the long-term fixation is, again, biologic. The bone cells grow into those pores and give you your fixation. Same thing with the cup. You ream the acetabulum to a certain size. You insert the cup of the same size. The initial fixation relies on the screws because that cup is just a hemisphere and it will toggle around, so you have to hold that cup in place. The long-term fixation is biologic, and again, it is a technique that's not as popular as the press-fit because you're relying on the screws. Remember, the press-fit cup technique requires no screws. You wedge it into that tight bone. You hit the rim. That rim gets the compressive hoop stresses, and you don't need the screws. Line-to-line, on the other hand, relies on the screws. If you don't have good screw fixation, that cup's going to toggle and get loose. That's why most people tend to use the press-fit technique for the cups. There's a couple people out there still using line-to-line, but most people use press-fit. Remember also that Cancel's bone is not weight-bearing. The stem must be adjacent to cortex. Clemow showed that the shear and torsional strengths of a non-cemented implant are much stronger when adjacent to cortical bone as opposed to Cancel's bone. In fact, about 3 times as stronger. And what we used to do is that we thought that, if you see in the slide on the left, we used to put these porous-coated implants against the Cancel's bone because we thought that that bone was, quote, more metabolically active, that the bone cells are more apt to grow in. And it's true, they did. The only problem is that that Cancel's bone with loading would shear and fall apart. And what we found out is that the cortical bone is just as metabolically active, and you have that loading onto the outer cortex, which is simulating the native hip. And that's the type of contact that we need. So if you're using any implant, you want your implant to be loaded against the anterior and posterior cortex. in those areas. So I've thrown a lot at you. One little mnemonic that's helped us for the test is the mnemonic rule of 50s. First of all, you want cortical contact, but if you just remember the 50s rules, it'll get you in the ballpark. You want to keep your gaps less than 50 microns. You want your pores between 50 and 150 microns. You want your porosity not to be greater than 50%. And you want your micromotion less than 50 microns. And they'll give you some ranges, but if you just try to remember that 50s, McPherson's 50s, that'll kind of get you there, okay? Now, there's another form of biologic fixation. That's what we call grip blast fixation. It's basically a way of what we call bone on growth. What you're doing with a grip blast stem is you're blasting it with some particles, either hydroxyapatite beads or glass beads, and you create literally micro divots in the metal, and the bone grows onto these divots. And if you do it right, the peaks and valleys that are these divots are similar to the openings seen in porous-coated surfaces. So you've got to pick the beads of the right size. You hit the metal, and you get these little valleys that are similar to the pores, which you would normally see for a porous-coated surface. And the bone grows into these valleys, providing a micro-interdigitation. And that's what we describe as bone on growth, not in growth. But still, it's a biologic fixation. So what you have here is your initial press fit. You hit that metal with the beads and blast it, and you get these little divots. And what happens is that the bone grows into these beads and valleys, or these peaks and valleys, and you get your interdigitation. So your long-term fixation is, again, biologic. The surface roughness is the important critical factor in describing how well these grit-blasted on-growth stems work. The roughness is, by definition, the average between the peak to valley of the surface. And the studies have shown that there's a linear correlation between implant surface roughness and push-out strength, as opposed to porous-coated surfaces where pore depth is the critical factor. The critical factor in grit-blasted stems is the surface roughness. The rougher the stem, the better bone-on growth you're going to get, and that kind of makes intuitive sense. The success, though, is much more dependent on stem geometry. Since you don't have a good porous coating, you really got to wedge these bad boys in there, and you got to wedge them tight. And generally what you see are these sharp tapered stems wedged right in there. They have to be a very, very tight press fit. The grit area needs to be pretty much extensile because you don't have the same strength as you do with a 3 or 4 layer porous coating. So the grit blasted stems tend to be extensively coated all the way to the tip. Again, the drawbacks of these are it's bone on growth, it's not in growth, so the interface is not as strong. The fixation basically is a half pore to 1 pore deep. And if you don't wedge it in good technically, you're going to have stems settling. And that's the main drawback with press fit grit blasted stems. So in grit blasted fixation, stem design and technique are very important. It's not as forgiving as the porous coated implants. The long term is what we don't know is whether these extensively porous coated or grit blasted stems will stress shield. Probably not like the big AML porous coated stems. Hydroxyapatite is a coating on the surface of an implant. It is osteoconductive only, not inductive, but osteoconductive only. It allows for more rapid closure of gaps. Basically, the bone cells see this hydroxyapatite coating, and as you're implanting it in, some of these cells will adhere to the HA surface and proliferate, so you'll have gap closure from the implant towards the bone, and then bone closure from the bone towards the implant. So you have a bidirectional closure of gaps, and so your fixation is stronger and quicker, but the long term, nobody's really shown that it's provided any stronger fixation than just porous coating alone. The success, though, if for test questions, is what you need is high crystallinity. If you have high crystallinity, you have low dissolution. If you have amorphous areas, those areas dissolve and then the HA falls apart. So high crystallinity and avoid the amorphous areas. The optimum thickness is 50 microns. Add that to your rule of 50s. If it's too thick, the coatings will crack and shear off. So you want them around 50 microns. Again, surface roughness of the metals on the metal helps hold these implants on, or holds this surface on. So you definitely want to put them on a grit blasted surface area, or my preference would be porous coating. Remember that hydroxyapatite alone may delaminate in the long term, and if you have a smooth surface underneath, the bone's not going to grow into anything, so you're relying basically on the HA. hydroxyapatite on a porous coated surface is probably a better choice because the bone grows onto the HA and then later on can go into the pores and get a long-term fixation. So if you look at uncemented total hips, you have multiple permutations in terms of design. You have the extent of the coating. It could be proximal or proximal 2/3 or hybrid. For example, porous on the top and grid on the bottom. The technique is either press fit or line to line. The metals are cobalt, chrome, or titanium alloy. The body designs are different, straight, bowed, taper. The surface coatings could be grid, porous, smooth, HA, or hybrid. And you'll say, well, what stem is best, and what do I answer on the test? Well, what you need to know is that you can't make a blanket statement about the long-term effectiveness of non-cemented stem fixation because there's so many different designs and permutations out there, and they're not going to test you on that. What they will test you on is this, is that porous coated hemisphere cups have a reliable long-term results. You can make a hemisphere only one way. It's a hemisphere cup, and you can put beads on it, or you can put a rough surface and get a porous coating, but they work long-term and been proven. So a porous coated hemisphere cup is better than a cemented acetabular cup. That will be tested. If you look at the NIH consensus statement, what the gold standard is, 7, 8 years ago, it used to be a cemented hip. The gold standard, which I would say is the best way to answer now, is a hybrid total hip, which is a non-cemented, porous-coated hemisphere acetabulum with a cemented femoral stem. And that was based on the consensus statement, which is at this time a cemented femoral stem component using modern cement technique paired with a porous-coated acetabulum gives long-term results. And the reason is that when they had the consensus statement, they had all these experts in there, Charlie Ng and Galani and everybody else, and nobody could agree what was the best non-cemented stem. So they left it with cemented stems because, remember, the cemented stems are loaded in compression and they last a long time. So the gold standard, I still think, is a hybrid total hip, except if on the test question they lead you down the path, a young, active patient. Young, active patients will do better with non-cement. And they'll usually say somebody who is very young tends to be relatively active. They're leading you down that pathway. Okay. One thing you need to know about stress loading on these implants is that the extent of the porous coating tells you where you're going to load. In a proximal porous coating, the load is transferred from the stem to the bone. It's transferred in the upper metaphysis and proximal diaphysis. You see here, the porous coating is just on the top, and the load is coming through that upper metaphyseal or metadiaphyseal junction. In contrast, if you have an extensively porous coated stem like an AML, you have the load transferred from the stem to the bone. The load bypasses the proximal femur, and fixation is distally, giving you what we call spot welds, which is an in-training and board question. What you'll see on the x-rays is that you'll see the spot welds down below at this area. The load bypasses the metaphysis, and you get these spot welds. If you look at this x-ray here, those areas of bone concentration are not a pedestal. A pedestal is seen at the tip of the stem in zone 4. If you see the bone consolidating around zones 5 and 6, that is bone consolidation from an extensively porous coated stem, well fixed, called a spot weld. Now, if you look at a cemented stem, you'll say, well, maybe it's loaded proximally, but it's not. The load actually bypasses the proximal femur, and also with a cemented stem, you get proximal stress shielding. This is the cement mantle, and basically the load comes out distally. This is based on evidence shown here, for example, and others, but Pritchard has shown with DEXA studies that with a cemented stem in the proximal bone area, you have a significant amount of bone loss over time. AML, which is an extensively porous coated stem, also has proximal bone loss, but a proximal porous coated stem, you have the most minimal decline. So in terms of stress shielding, proximal porous coated stems have the least amount of stress shielding seen. And remember that cemented stems do stress shield. This is an example of stress shielding. The slide on the left is an AML stem. You can look at it at 5 years. You can see the amount of bone loss in that area. Proximal stress shielding represents proximal bone loss. It usually is associated with a large, stiff, cobalt chrome stem that is extensively porous coated. And if you look at the test questions, it turns out that stress shielding is more related to stem stiffness than it is the extent of the porous coating. Stem stiffness is the main determinant. Porous coating is not to be as important, but is a factor. The problem has to do with molluscous mismatch between the stem and the bone. If you look at the middle bullet there, stem size stiffness of a stem is related to the area moment of inertia, which is directly related to the fourth power of the radius. So if you have a stem that's 2 times as large in diameter, it's going to be quadruple the stiffness. And stiff stems have a big modulus mismatch, and that's where you're going to get your stress shielding. So cobalt chrome is a stiffer metal than titanium, so that's going to lead to stress shielding. Stem size, a large stem is going to stress shield more than a stem that's not, or a smaller stem. And also stems that have a different solid geometry tend to be stiffer. For example, more stiff stems are the solid stems and the round stems. If you hollow them out or slot them or flute them, then you're going to have less stiffness. So stiffness is not just a porous coated issue, it is a stem stiffness issue, number 1, porous coating issue, number 2. And they'll ask you that on the question. That was an in-training question, I think, 2 or 3 years ago. If you look at cement technique, this is for your review. Everybody talks about first, second, third generation technique, but it's not really written well anywhere. So I went to the godfather himself, Bill Harris, and sat him down and asked him. This is it, right from his mouth. First generation technique, finger packing, no canal preparation, just put the cement in, no plug, no gun, put in a cast stem. They had sharp edges, and they tended to fail with cracking at the edges. The second generation technique included insertion of a cement with a gun. You had pulse tile lavage to clean out the blood. You prepped out the canal and dried it. You used a cement restrictor. Used rounded borders so you didn't have any sharp edges, and you intended to use a collar. The third generation basically was what we call porosity reduction, reducing the pores in the cement by centrifuge or vacuuming. You pressurize it with techniques to squeeze that cement in, and you intended to use pre-coated stems, a little bit rougher surface for cement interdigitation, right, with the prosthesis, and use a centralizer to keep from getting mantle defects. If you look at some non-cemented cups versus cemented cups, Ranawat always says, well, remember, cemented polyethylene cups do well if you exclude the inflammatory conditions, protrusio deformities, dysplasia, bottoming out, which is the mantle defect or excessive bleeding. It's hard for me not to get all those. But if you excluded all those, the long-term fixation of cemented sockets is similar to uncemented sockets. Basically what he's saying, if you do it right, it will last a long time. But I tell you, there's a lot of guys out there, including me, that can't do it right all the time. That's why we've gone to porous coated sockets. But just remember that if you do it the technique correctly, you can get relatively good long-term results. This is an important thing to know, is that a mantle defect in a cemented stem or a cup is a place where the cement construct touches, or where the prosthesis touches bone and there's no cement in between. It's an area of concentrated stress, and it's the only associated area of increased loosening. For example, if you see this stem tip here, that prosthesis is touching bone. That's an area of stress concentration, and that's more prone to failure. Prosthesis with mantle defects, which is shown by Bill Harris and Tom Smallsreed, have a higher rate of loosening. And that's the only thing that they showed in terms of cement technique. So if you had a mantle defect, you're at an increased risk for mechanical loosening. And that goes back to Ranawat's stuff, that if you bottom out and touch, or you have a bloody interface where the cement slides out and the bone touches the prosthesis, that's where you get a mantle defect, and that's where you're going to get loosening. Stem breakage, remember for the test question, the failure mode is cantilever bending, and it doesn't matter whether it's a cemented stem like you see on the left or a non-cemented stem, which is seen on the right. Basically, the stem is fixed distally and potted, and it starts to cantilever bend around the midshaft. It's seen more with cemented stems because they tend to be of smaller diameter. But you can use a small diameter non-cemented stem and get the same cantilever bending, and it'll break. Just remember the mechanism is cantilever bending. Okay. Anatomy questions. Remember that the sciatic nerve, this is a right total hip, and you can see that there's a buttonhole dislocation, and that arrow shows a sciatic nerve. The sciatic nerve comes closest to the acetabulum at the level of the ischium. That's an in-training and board question. The most common reason for sciatic nerve palsy is errant retractor placement placed around the ischium. It slides off and grabs onto the sciatic nerve. Remember also that in dysplasia, the risk of nerve palsy is increased with lengthening over 3.5 centimeters. That was shown by Tom Smallsreed. So lengthening over 3.5 centimeters is a key number to remember. This is a left total hip here. The ball and socket are in the corner there in the black. What I've done there is pulled off the gluteus maximus tendon, and that circle shows you right underneath the gluteus maximus tendon and quadratus femoris lies the medial femoral circumflex artery. So if you put your bovie straight down in that area, you will hit the medial femoral circumflex, not the lateral femoral circumflex. So right underneath the gluteus maximus tendon or quadratus is where that artery lives. This one, I don't know why the picture didn't show up. This has been on an in-training last year, every other year, and on the boards, is that the transverse acetabular ligament, which is at the bottom of the acetabulum, you have the cotyloid pads. Connecting the cotyloid pads at the bottom is the transverse acetabular ligament. You shove a retractor down below that so you put so you can see everything. If you shove it too deep, you're going to hit the obturator vessels. And what happens if you hit the obturator vessels? Generally, you just pack it off. You don't have to flip the patient over. Specific disease questions for total hip. Sickle cell disease is associated with early loosening. Psoriatic arthritis makes sense. You have all these exposed skin lesions. They're more prone for infection. Ankylosing spondylitis are bone formers, so they're more prone to getting heterotopic ossification. Heterotopic bone can be treated with low-dose radiation, one-time dose, 750 millirads. Osteolysis is an issue that you need to understand with total hips. It's one of the main reasons why we went to non-cemented implants. Osteolysis is a histiocytic response to wear debris. The classic finding is bone scalloping. It's the hallmark. This is bone scalloping on these x-rays. It is not mechanical loosening. You see these rounded scalloped areas, and that is the hallmark finding of osteolysis, not infection. I want you to look at that in your slides later on. It is seen with non-cemented and cemented constructs. It is a problem of polyethylene debris, which is the main culprit, and it is a bearing wear problem. The types of wear of polyethylene are abrasive wear. So if you have a rough head, you scratch on the polyethylene. That's a cheese grater effect. That's abrasive wear. The most important wear phenomenon is adhesive wear, which causes the main osteolytic problem. If you have poor technique and you have third body particles like cement debris or metal debris in there, you can get third body particles. But it is adhesive wear, which is the most important in terms of osteolysis. If you look at the studies, osteolysis represents the sub-micron shedding of polyethylene particles, not micron particles, but sub-micron particles, a result of adhesive wear generating billions and billions of particles. This is a SEM micrograph of polyethylene. You can see the little polyethylene beads on the left. On the right, you'll see a wear simulator. And at the bottom, those are the little polyethylene beads. And if you magnify it, what you see here, these are the little beads of the polyethylene on the cup. And at the bottom of the wear simulator, there's those same beads. And if you look even closer, you see these little tails. And what is happening is that these beads are literally being pulled off. It's adhesive wear. As that bearing ball comes through, it literally pulls those beads off. And that is adhesive wear. And those are submicron in size. That SEM is about, that's a 1 micron bar there. So those particles are about a half micron in size. And you're generating billions and billions of particles over the life of that prosthesis. And what happens is that these particles get phagocytized, they get further macrophage recruitment, you get release of osteolytic factors. The most common source is the bearing itself, which is polyethylene metal. You get phagocytosis, activated macrophage, and osteolytic reaction, which includes the release of interleukin-1, tissue necrosis factor alpha, also known as osteoclast activating factor. Prostaglandins are released, primarily PGE and PGI2, oxide radicals, hydrogen peroxide, and acid phosphatase. The most important one is acid phosphatase because it is acid phosphatase that dissolves bone, and that's where you get that scalloping. So that's the most important issue in terms of osteolysis. And what happens is in the intra-articular process, you get this polyethylene debris generation. Because these particles generate inflammation, you get a fluid buildup. It's like rubbing your eye. You start to tear up and get the water in there. It builds up pressure. And then you get this debris disseminated through what we call the effective joint space, which is described by Smallsreed, who got the Charnley Award for this. And it is an area, the effective joint space is the area where the debris around a hip or a knee or a shoulder contract, and basically it's around the entire prosthesis, around the screws, and it's not just isolated to the joint itself. So debris can go behind the cup, behind the stem, and behind the screws. And basically, bone lysis can occur anywhere within the effective joint space. And the reason it goes to a certain area is what we call the path of least resistance. So if you have a well-sealed femur, then the path of least resistance will be the screws behind the cup, and that's where you'll get most of your osteolysis. If, on the other hand, you have a non-cemented cup without screws, maybe it'll go down the stem. But basically, the osteolysis, because of the pressure, will go through the path of least resistance, and that's where you get your osteolysis. Lytic lesions around screws and non-cemented cups are an issue. The in-training question has shown that what you want to do when you have a large amount of osteolysis around the screws, you pluck out the polyethylene insert, and leave the cup and then insert bone graft through the holes, or a little small trap door in the ilium just above it. So I saw that as a test question 2 or 3 times. So if you have a well-fixed cup and a lot of osteolysis in the screws, pull out the screws, bone graft the screws, but don't revise the cup. Particle generation is related to many factors, including the activity level of the patient, the implant design, the bearing material, good plastic versus bad plastic, implant fixation, if you're circumferentially porous coated versus partially porous coated, surgical technique. You don't want to have a lot of head scratching with your technique, and the polyethylene processing, which we'll talk in the next lecture. The osteolysis threshold is related to the concentration of the particles in the effective joint space. Once you reach a critical threshold, you start to get that osteolysis phenomenon, which is basically a number of particles per volume. You have to also look at the biomaterial reactivity. All particles generate osteolysis, including cobalt, chrome, and titanium, but because polyethylene is so much more prevalent, because it's the soft part of the system, those are the main culprit. The osteolysis threshold is also related to the individual body response of inflammatory particles. There are some people that you don't see much osteolysis because they just don't react to it. Also, some people clear out the debris faster than others, so some people will clear polyethylene out into the lymphatics a lot faster than others. So a lot of variables involved. What we do know also in terms of these in generating debris is you want to avoid titanium heads. They tend to scratch easy, and that creates abrasive wear, generating a lot more particles. So you don't want to use titanium heads, and you don't want to use cemented titanium stems, because with cantilever rotation and bending, you generate polyethylene or titanium particles which get into the system and scratch the head and then scratch the cup. So avoid titanium heads and do not cement titanium stems because they scratch real easy. All right. In terms of the amount of debris generated, it's related to what we call volumetric wear, not linear wear. Volumetric wear is basically where a head wears into the cup. You have a cup of a certain radius, which is over there on the left, and it wears in a northward direction, generating what we call linear wear. The volumetric wear is basically the volume of the cylinder. So volumetric wear determines the extent of the particles generated. The volumetric wear, if you round it off to a rough formula, it's related to pi r squared times the linear wear rate, which is basically the area of a cylinder. Just remember that it's related to the r squared. So the higher the ball, the larger the ball, the more volumetric wear, the more particles you're going to generate. So you have this trade-off. You could use the small standard Charnley stem, which is 22 millimeters, and what you're going to see there is you're going to have higher stresses at the head interface, so you're going to have a high linear wear, but it's low volumetric wear, and it's not going to generate a lot of debris, and you're not going to have a lot of osteolysis. The problem is that over time that's going to wear through and it's going to wear out. On the other hand, you use a large 32 millimeter head, you have a big ball, large volumetric wear, you're going to fail by osteolysis. The polyethylene is not going to wear out, but you're going to sure get a lot of osteolysis. So the trade-off has always been linear wear, volumetric wear. So what you want to do is pick out somewhere in between, and that's where we've traditionally gone to the 28 millimeter head, because that's the best compromise. It has less volumetric wear than 32 millimeters. It has less linear wear than the 22 millimeters and gives you a little bit better hip stability than 22 millimeters. And that's how we arrive at 28 millimeter heads, because of the osteolysis factor and volumetric wear. And that's how we came to it. These are some of the things you see in the studies about Gruen zones. Tom Gruen described the 7 zones around the stem where you can get loosening. Just remember that zone 1 is the area where you're going to see radiolucent lines first in a cemented stem. As Tom Gruen says, that's because that's where the action is. Because remember that stems load with cantilever bending, and similar to when stems break, when they start to loosen, you'll see the radiolucent lines first in zone 1. That's an in-training question. Charnley and DeLee, you break it into zones 1, 2, and 3. You take the center of head and take a right angle. You tend to see the radiolucent lines in zone 3, and that's because as these cups get loose, they start to compress north. So you tend not to see the radiolucent lines in zone 1, because as it gets loose, it's loading. You tend to see the radiolucent lines in zones 2 and zone 3 as it gets loose and starts to migrate up. Going on to a different topic, we're going to talk about osteonecrosis of the hip. The final common pathway described by J.C. Jones is intravascular coagulation. What you have is an intraosseous microcirculation coagulation followed by a generalized venous thrombosis, and you get a retrograde arterial occlusion and death leading to the dark side. Intravascular coagulation is always triggered by some underlying etiologic risk factor. You need to know them. These include hypercoagulable states, alcohol, dysbaric disorders, i.e. deep sea diving, hemoglobinopathies, hypercortisolism, including anabolic steroids. Remember that anabolic steroids can cause AVN. That was shown by Ken Bettine, who was up the road in Fort Collins. Malignancy, radiation therapy, pregnancy, and trauma. The risk factors also include antiphospholipid antibody syndrome, hyperlipidemia disorders, sensitivity reactions, i.e. allergic reactions, viruses, and protease inhibitors. Guy Paymon at UCSF has shown that protease inhibitors do show some evidence of avascular necrosis. The hypercoagulable states, I won't go over them, just remember them. Protein S and protein C have been the traditional ones that you'd like to see as causing hypercoagulable states, but there's a lot of other ones here, and you'll see them, and they're in your handout. These are, if you have lipoprotein small a, is another one that you'll see more commonly, homocystinuria, and excess or factors 8, 9, and 11. If you look at the classification, the generalized accepted classification is in the United States is what we call the Steinberg classification. It's not FICOT. FICOT didn't use MRIs. The Steinberg classification uses the MRI, and Steinberg classification is adopted by the Academy because Steinberg was on the Academy of the Hip for osteonecrosis, and so it's his classification. Thank you very much. But what you need to know about that is that the important thing about the staging system is stage 3 represents subchondral collapse, and that's the crescent sign. When the subchondral bone collapses, you're out of round, you're going to get pain, you can't make it better. And that means that the bone is beginning to collapse. It's a poor prognostic sign. So it doesn't matter on the test whether it's a FICOT 2 or a Steinberg 3. If you see a crescent sign, that's the bad thing that you want to know for the test. When present, core decompression is not going to work because once it's collapsed, you can't make a collapsed bone regenerate to a round surface. For example, if you look at this x-ray, this is a avascular necrosis, and it's very subtle here. You've got a crescent sign with subchondral collapse, and then it goes on to a total hip, and you'll say, look at that x-ray. Man, why did that guy do a total hip? Well, this is the ball that I harvested from that. That's that patient's pathologic specimen, and that's what it looks like. And that crescent sign really means that that thing is really collapsed down and is out around. Okay? Stage 4, Steinberg, is flattening of the femoral head, and then stage 5, acetabular changes, and then 6 is advanced degenerative arthritis. Steinberg takes his classification to volume percent, not just basically area percent. Volume percent basically is AP view and lateral view. So if you have 50% involvement on the AP and 50% involvement on the lateral, 50 times 50 gives you 25%. That's 25 volume percent. So if you look at his numbers, A is a 15 volume percent. That's a pretty significant effect. So if you have a 30% volume percent, which is C, that's almost whole head involvement. Okay. In terms of head collapse, what you need to know for the test is that the size of the necrotic lesion most strongly influences the risk of head collapse. The larger the area of necrosis, the more likelihood of head collapse. The treatment options for AVN are core decompression, fibular strut placement, osteotomy, and hip arthroplasty. The rationale for core decompression was described by Hungerford. And he has always stated that with avascular necrosis, you have interosseous hypertension present in all stages of the game. And he's also told us that bone is what we call a Starling resistor. What that means is that the bone is a solid container, and if you have inflammation within that solid container, then you're going to put pressure on the vessels, and then you're going to have decreased flow. And that if you did a core decompression to decompress that pressure, then you're going to get healing, and you're going to get reverse of the process. So in terms of the pathomechanics, bone ischemia because of the Starling resistor plus weight bearing, those two together cause collapse. And what you want to do is reverse that process. So Hungerford has always thought by creating a wound, i.e. causing a break in the system, stimulates neogenesis, which is healing. So the principle of core decompression is you put a hole in the bone so you get rid of that interosseous hypertension so that it relieves it. It makes you feel better right away because you get rid of that hypertension. And then the hole goes on to heal because you've stimulated the process of healing, i.e. neogenesis. So the core heals by adjacent creeping substitution. What you need to know is that you can't have any subchondral collapse, i.e. a crescent sign. If you have a crescent sign, it's already over. Core is not going to help. Also, any level, any stage of the game where you're taking steroids, poor results, multiple studies. So if you have somebody with with avascular necrosis on steroids and is going to stay on it, don't do a core. You have to be meticulous with your technique. You have to go all the way up to the subchondral surface for the core decompression. The difference now with the vascularized fibrillar strut is a large core hole for insertion of a mechanical strut to keep that bone from collapsing. But also the other thing that Urbanic describes is you extirpate or literally remove all the necrotic bone. And that's the difference between a core. So what happens is you take out and literally shell out all that necrotic bone, put a strut in to keep the subchondral bone from collapsing, and then around that strut you put cancellous bone. So the core and strut together stimulate neogenesis. So here's an example. This is a large reamer all the way up to the subchondral plate. What you see in the middle side is a burr removing all of the necrotic segment. After that, you see the fibrillar strut going in, and then around that big, large hole, you put in cancellous bone and bone graft it. So you literally take out the entire necrotic segment and bone graft it, and that's why there's been success with that treatment. Conversion to total hip, as you would expect, the worse the problem, i.e. the worse the Steinberg classification, the higher the rate of the conversion. As a general rule, the large necrotic segments, the indications for a fibrillar strut, the way I've kind of put it together is if you have a large necrotic segment where you're at risk for collapse, that's probably the best bang for your buck for your fibrillar strut. This is not talking now no crescent sign. So if you have an MRI and you have 3/4 of your head involved and that thing's going to go on to collapse, if you want to keep that from collapsing, you put it in and shore it up with a strut, take out that necrotic bone and bone graft it. And if you leave it alone, it's going to collapse. So that's why I think a fibrillar strut in that indication is a really good thing to do. If you remember that subchondral collapse means that you've lost the articular surface architecture, the ball game's over, there's a tendency not to do the fibrillar struts in the later stages, although Urbanic has done it. As a general rule, the most appropriate treatment for osteonecrosis with degenerative arthritis after the crescent sign is seen is total hip replacement. Not bipolar, but total hip replacement. And I've seen that on the test questions. Now, periprosthetic fractures, remember this rule. If you see a broken hip on the test, if the stem is loose up top, you've got to revise it. Forget about all the other options. So first rule, revise the stem if it's loose and fix the fracture, of course. And you generally fix it with a long stem, extensively porous coated prosthesis, cerclage cables, plus or minus struts if you need to. So here's a case, broken stem. You can see that the stem is loose up top, so you've got to revise the entire construct, okay? Now, going down the line, if the stem is stable and it's just a trochanter fracture, then you can treat that basically non-operatively. And if you have a break in the proximal metaphyseal area and the stem is fixed in the diaphysis, again, you tend to treat this non-operatively with a brace. Or if there's evidence of stem compromise, then perhaps fixing it. If now the areas where you see the fractures are most are at the stem tip. And why do you see stem tip fractures more commonly? It has to go back to the same reason that we talked about before with stress shielding and modulus mismatch. You have a stem that comes down to the tip, and you have a modulus mismatch. You have relative bending at the tip, and that's where you're going to get your break. So tip fractures are the most common fractures that you're going to see. So the rules are if you have a fracture at the stem tip and that involves less than 25% of the prosthesis, whether it's cemented or non-cemented, that means that the stem is stable. You don't have to revise the stem, so you fix it with plates or screws, allograft struts, or if you want to, you can revise it. So there's 3 or 4 choices. So they're probably not going to ask you that on the question. What they will ask you is this one, because it's only one answer, and that is if you're at the stem tip and it involves more than 25% of the prosthesis and it's cemented, that means that you violated the cement mantle. You're no longer fixed the bone. You have to revise the stem. So if you see a stem tip fracture, more than 25% of the surface, stem's got to be revised. There's only one answer. That's where they're going to ask you the question. Now, stem tip fracture, more than 25% of the prosthesis, non-cemented. This is a good question that they may ask you. Well, if you have a proximal porous coated stem and all your fixation is up top and you have the fracture at the tip and it goes more than 25%, you may get away with just fixing it. If it's an extensively porous coated stem and you break at the tip and you fracture and ruin your fixation, then you have to revise that because most of your fixation is down at the tip. Remember what we talked about with AML stems? So again, this one, there's a lot of choices there. They're going to tend not to ask you that question because there's too many choices. Just remember the principles. If you have a supracolumnar fracture way below, down by a revision, you tend to treat those non-operatively with a cast brace or plates and screws. You know, a DCS screw, or the AO guys want to put those plates on the outside. That's fine too. If you have a paraprosthetic fracture distance to the stem tip, you treat that just like any other supracolumnar fracture that you want to fix. There's no other specific rules for that. Okay. The other thing you got to know is acetabular screw placement every single year. You got to know this, know the zones, recognize the safe zones, no screws through the medial wall. So here it is. Here's your acetabulum. That is a right hip hemipelvis. You draw one line. Line A is this line right here. That's that line right there. You start out from the ASIS and you draw a line to the ischium, and as line B is a line perpendicular to it. And the way I memorize this is that you go from the ASIS to the ischium, ASIS, and just in front of that is anterior superior. So AS, anterior superior. Anterior superior is the zone of death, and that's where you hit the external iliac artery and veins, and you do not want to put screws in the anterior superior zone. Right behind that is posterior superior, and that's this area right there. That is the safe zone, and there's where you want to put your screws. Remember, inferiorly, anterior inferior, which is right here, that's where you put that acetabular retractor, where you can get the obturator artery and nerve. You want to avoid the screws in that area. And posteriorly, you can put screws there, posterior inferior, but you can't put them too long because you'll hit the sciatic nerve. But remember, anterior superior, zone of death, external iliac artery. They're going to ask that one way or the other on that test, guaranteed. So study that. It's like memorizing the brachial plexus. Memorize this, memorize that graph. Okay. Now, revision total hips. A loose total hip, the clinical presentation, usually the first recognizable symptom is startup pain. It's the first and most common presentation. Startup pain, if it is in the thigh, usually is a loose femoral stem. If it's in the groin, it usually represents a loose acetabular cup. You've got to identify the bone defects. Segmental defects are a loss of the rim or the column or the medial wall. This is talking about the acetabulum. Cavitary are little holes in the cancellous bone, or you can have a combined deficiency. So if you look at his diagram, this is a cavitary deficiency. The rim is intact. Those are little holes in the cancellous bone. If you go on, this is a cavitary deficiency and a segmental deficiency with part of the rim intact. You can see the cavitary deficiencies are there. The rim deficiencies are in this area right here. Okay? The important thing to know is that you've got to have an intact rim for an acetabular cup. So that is a general rule for a revision cup. Non-cemented porous-coated hemisphere cup is the preferred technique of revision with screws because the bone is damaged. And generally, you can accept 2/3 of the rim intact for a rim fit. So if you're missing 1/3 of the rim, you can still get a relatively press-fit technique with screws and particulate bone graft. And that's the number one answer. Okay? So you tend to fill the cavitary defects with particulate allograft. If you have protrusio deformity, i.e. that medial wall is deficient, you have these deep-seated metal cups you can use. The technique, again, is to fit the rim, to get that rim fit. And again, you've got to use screws for the fixation. And if you want to get that rim fit a little bit better, it is okay to ream through the medial wall a little bit to get that good rim fit. If your rim is deficient, you've got to go to a cage. And that's what you've got to remember for the test. What you can use with the cage is you can put particulate graft behind it. If it's a big hole, you can put an allograft. But the point being is you've got to use some type of reconstruction cage because the earlier data showed that if you use a bulk support allograft without a cage to support it, you had high failure rates. So that's because you put this big piece of dead bone and you loaded it excessively with shear and tension forces, they fail. So if you put, for example, a bulk allograft with a bipolar head, the most common reason for failure is bipolar migration because the graft resorbs. The most common reason for failure for a cemented or non-cemented cup into this allograft is, again, migration because the graft resorbs. So what you've got to do is you've got to stress load these with some type of reconstruction cage, either a Gons ring or an anti-protrusio cage that gives you some extra support to allow that graft to heal. And that's the technique that you need to know. On the femur side, you can have segmental deficiencies, which is loss of the cortical tube. You can have cavitary deficiencies, which is basically a dilatation of the endosteal canal, which we call ectasia, or it can be combined. As a general rule, if your tube is intact and there's no segmental loss, the preferred revision is a non-cemented stem, extensive porous coating, and that's the most common solution, and that's what you'll see on the test. Loose total hip, the new implant should bypass the most distal cortical defect by a minimum of 2 cortical diameters. For example, if you have a hole in your bone somewhere, that stem has got to pass 2 cortical diameters below it. If you have a stem with osteolysis, like you see in this area here, that's an area of stress concentration. Your stem has got to be 2 cortical diameters below that osteolytic lesion, or else you run the risk of fracture. Just remember that, 2 cortical diameters. The other technique for revision is impaction bone grafting. It is a technique to build up bone stock. So the main advantage of using impaction bone grafting is to reconstitute bone and an ectatic femur. You can use allograft struts with cerclage cables on the outside for weak tubes, but the reason for it is to build up bone. What you do is you put this allograft bone inside the ectatic bone, you prepare it with serial broaching, and then you cement in a polished stem, which has a tendency to subside just a little bit and reach a steady state. The allograft heals to the end osteobone, and the cement stays bonded to the allograft. It's a little bit of leap of faith, but basically, if you do it right, it works. The most common complication is subsidence. If you don't pack your allograft in tight, the allograft's going to get loose and it's going to subside. It's technically demanding and time-consuming. I don't use it because my personality is not suited to this type of technique. It tends to be falling out of favor, but some people still do it with success. Segmental deficiencies of the femur. You're missing the tube. A non-cemented stem with extensive porous coating is the main choice. You tend to use allograft struts with cerclage cables for the cortical defects. So for example, here's a revision stem with a big hole. You put allograft struts on the outside of that for that segmental deficiency. And if you have complete loss of, say, the proximal femur, you can use a bulk support allograft for the proximal loss. If you're going to use metal, or if you're going to use bone instead of metal, you have to cement the prosthesis to the allograft, step cut the allograft into the native bone, and cable it with either cerclage cable. Instead, if you want to, you can use these big calcar replacing prosthesis, calcar modular calcars, or endoprosthetic metal replacing prosthesis. But the thing that they're going to ask you for the test question, if you're going to use an allograft, you've got to step cut it and you've got to cement into the allograft because the allograft stays dead. That's shown by Mankin's work. Okay? You've got to also know for the test the relative modulus of elasticity. These include from the top to the bottom in terms of Young's modulus. Ceramic is the highest, cobalt chrome is next, stainless steel, titanium, then cortical bone. Just remember that ceramic is the hardest because it's very hard and brittle, so that's how I tend to remember it. Titanium tends to be more flexible. After that, you have methyl methacrylate and polyethylene and cancellous bone. So the thing I tend to remember for the test is that ceramics on the top, cortical bone here, cancellous bone here. In between those two bones, the cortical and cancellous, is cement and polyethylene. And I know that I can put my fingernail into polyethylene and scratch it, so it's a little bit easier, a little bit softer than cement. So I remember the ceramic, I remember the cortical bone, cancellous bone, polyethylene, and cement are in between. And then somehow I figure that titanium is less stiff than cobalt chrome. And people don't ask about stainless steel anymore because we don't use it. So that's kind of how I figure that one out. And then for the sports guys, you got to know that tendon ligament crap. All right. The coefficient of friction, I'm not sure if this will be asked on the question, but this was seen. I've seen it on 2 in-training questions. Articular cartilage, the relative values in terms of order. Articular cartilage has the lowest coefficient of friction. The next one is cobalt chrome on cobalt chrome, i.e. metal bearings. Then metal polyethylene, ice on ice, and then steel on steel. But remember that cobalt chrome on cobalt chrome has a relatively low value, and I'm sorry, I didn't put the numbers in, but just know the order. Articular cartilage, cobalt chrome, metal poly, ice on ice, stainless steel on stainless steel. Okay, so let me get off to my next one. We've got a bunch of these to go. Don't leave, everybody. We've got a couple more. I have these all open up, but they freeze this computer. Mark's got to get a stronger computer with a lot more RAM. Okay, this is the bearing lecture going on with hip replacement, knee replacement, or shoulder replacement. This is all the things that are up to date. Bearing couples for hip or knee replacement. The traditional bearings have been metal polyethylene or ceramic on polyethylene. The newer bearings are now what we call hard on hard, which are metal, which I tend to like the most, and ceramic on ceramic. Always remember that hard on soft bearings, the lubrication regime is boundary lubrication. What that means is that the asperities, i.e. the high points of the ball and cup on each other, make contact, and that the boundary lubricant, i.e. the synovial fluid, separates the surfaces just enough to prevent surface wear. So you are making contact every time that bearing moves. So the hard on soft bearings are boundary lubrication. Okay, the metal polyethylene bearing couples, the best one is cobalt chrome on polyethylene. Titanium and polyethylene is not as good because remember, titanium heads scratch. Stainless steel is not used anymore. It's of historical purposes because stainless steel is less forgiving or not as good in terms of its corrosion resistance. The main thing in terms of optimum wear of hard on soft bearings is surface roughness. So if you have a rough head, you're going to get more scratching, so we like to make them real smooth. The roughness of a cobalt chrome head has to do with the carbide asperities that stick out and cause scratching. In contrast, ceramic heads, you have a little bit residual pits on the surface which create scratching. So remember, carbide asperities stick out, and on the ceramics you have the pits. Also important in terms of optimum wear is the sphericity of the ball. If you're out of round, you're going to have high stress points, and that's going to cause increased wear at those high stress points. So you've got to have a smooth head, and you've got to have a nice round head. Okay. Remember that in terms of the titanium polyethylene bearing, it should not be used. Titanium as a bearing surface scratches easy, and it causes rapid polyethylene wear. We learned that very early on. In terms of polyethylene, the material used is ultra-high molecular weight polyethylene. There are many factors that make good polyethylene. The factors that affect polyethylene wear are the manufacturing of it, the sterilization, i.e. cross-linking, and the shelf life. I'm going to talk about these. Polyethylene can be manufactured in 4 different techniques, which is ram bar extrusion. So you put the plastic in a tube, you push it through a piston and heat it up, and you get these bars of polyethylene. And then from those bars, you machine your cup and in your inserts. You can have hot isostatic pressing into sheets and bars and then machine it from there. You can do compression molding, so you put it into a tube and compress it without any of this heating process. It's just at high torr and some high heat. And then what also you can do, the last one is direct compression molding, where you put it into a mold, press it, you get your polyethylene product, no machining. That tends to be the best wear. So the studies have now conclusively shown that better wear is consistently achieved with direct compression molding of polyethylene. And that's a definite test question. That's been shown in several studies. We also know that adding calcium stearate is bad. Calcium stearate used to be added to the machining process that kept the machines from corroding and allow the processing to keep from gumming up. But calcium stearate causes fusion defect, which weakens the mechanical properties, so we no longer use calcium stearate. There are, going on the processing now, you can process the polyethylene, i.e. sterilize it with gas plasma sterilization. You can use ethylene oxide, low dose irradiation, or high dose irradiation. And you've heard a lot about high dose irradiation for cross-linking. What you need to know about all these sterilization processes is that irradiation of polyethylene in air is bad, and I will go through that with you very quickly and explain to you the process. So to sterilize polyethylene, a lot of companies would take the polyethylene, put it in a room, irradiate it, and then store it. And what would happen when you irradiated polyethylene, what we didn't know is that there was an intermediate step where you got free radicals formed, and these free radicals could do 2 things. They could cause chain scission, which is oxidation, and this was seen in the presence of oxygen, or you could cross-link. And as it turns out, that cross-linking actually makes the chain stronger and improves the wear properties of the polyethylene. So if you have free radical formation, you can, and if you stored it in air, you can force it down the pathway of oxidation where you get the carboxyl groups and you get chain scission, and that decreases the mechanical properties and increases the wear. Instead, if you go in an inert environment, i.e. you package it in argon or nitrogen or vacuum packaging, you can get cross-linking, and that's desired, and that improves the wear resistance of the polyethylene. So what we learned from John Collier and others is that if you took polyethylene, sterilized it, and stored it in air, it greatly reduced the mechanical properties of the polyethylene, and this is where you were seeing a lot of this problem of early osteolysis in young active patients, and you were saying non-cemented hips didn't work because they had osteolysis. No, it wasn't the non-cemented stuff, it was the polyethylene, and it was the cycles and the stress and the wear. So in terms of cross-linking, you have improved resistance to adhesive and abrasive wear, and improves the wear rates both on simulator and clinical data. So in terms of the current status, you can sterilize your polyethylene with ethylene oxide or gas plasma spray. You get no cross-linking. You get a sterile product, but it doesn't have cross-linking. You can do low-dose irradiation, and that gets you some cross-linking. You say, well, if some cross-linking is good, maybe higher cross-linking is better. And in fact, that's true. In terms of the non-energetic sterilization processes of ethylene oxide and gas plasma, you have no significant effect of cross-linking, positive or negative. But as a rule, you generally have higher rates of wear. So if you took that same plastic and sterilized it in ethylene oxide, and then took the same plastic cups and irradiated them, if you compared the two, cross-linking products do wear better. Okay. So that leads us to highly cross-linked polyethylene. What you have there is better wear rates than the low dose. It doesn't make the polyethylene stronger. In fact, high-dose irradiation, in fact, lessens the mechanical properties of the polyethylene product. There are at least 4 different methods to cross-link at the high-dose level. The secondary processes change the distribution of the cross-link areas, and what you need to know, the take-home point here with high cross-link polyethylene is the effect of crystallinity. Polyethylene exists in 2 forms in that cup or tibial insert. You have what we call the amorphous areas where you get the cross-linking, and then you have the crystalline areas. The crystalline areas are not affected by cross-linking. Cross-linking is good. So if you have high crystallinity, you don't have a lot of cross-linking. So the problem here is that if you do any process that increases the crystallinity of the polyethylene, you're going to have higher rates of failure. So that is why you have to understand with high cross-linked polyethylene what the secondary processes are. And from the Hylamer experience, Hylamer failed miserably because their secondary processes increase the crystallinity. It is the amorphous regions that cross-link and give you the wear resistance. So the optimum crystallinity is 50 to 56%. Remember, max rules of 50s? Add this in, too. You want crystallinity around 50%, not over. Okay. So these secondary processes basically involve a heat annealing. So you heat up the polyethylene to change the structure and you arrange the molecular change into a more stable state. If you heat close to the melt point, you get not as much rearrangement, or you can heat it to overmelt, meaning you melt it literally. So if you heat anneal below the melt point, which is the secondary process, you get rid of the free radicals. So that's what heating does. You get some of those free radicals heated up, and you get more cross-linking, and that's good. And you have a little reordering of the molecular change. The problem is, if you heat anneal above the melt point, you get rid of the free radicals, but the heating process also increases the crystallinity of the polyethylene, and you get more crystalline structure. Well, it's a more stable state, but guess what? It wears awful because you don't have those amorphous areas for cross-linking. So high cross-linking is good if you do it right. Isn't that a wonderful statement, huh? So you've got to be careful about highly cross-linked polyethylene. Increasing the cross-linking also diminishes the mechanical properties of the polyethylene, and you've got to be really careful how you use it. In the hip, it's good because you're loading and compression mainly, but in terms of the knee, it may not be the best thing. Remember that highly cross-linked polyethylene reduces Young's modulus, it reduces the yield strength, and it reduces the fracture toughness. And specifically, it decreases the fatigue crack resistance, and it may lead to catastrophic failure if high stresses are applied, i.e. if you have edge loading in a total knee. So I think of high cross-linked polyethylene as being brittle, more like a ceramic. If it's more like a ceramic, it's going to crack more. And that's how I remember high cross-linked polyethylene. So remember that oxidized polyethylene has reduced mechanical properties, but also high cross-linked polyethylene does too. The difference between the two is the wear resistance. Oxidized polyethylene doesn't wear very well, whereas highly cross-linked polyethylene wears real well in the simulator and in vivo. That's the difference between the two. Okay. The last thing we need to talk about is product storage. Irradiated polyethylene packaged in an oxygen-free environment minimizes oxidation, and that is good. However, it has been known that free radicals can survive in polyethylene for as long as 2 to 3 years. And so depending on the packaging technique, oxygen can diffuse back into the polyethylene product, and the result is you get on-the-shelf oxidation. And the problem is that oxidation is directly related to the irradiation dose. So if you do high-dose irradiation and then you store it for a long time, you're going to get more oxidation on the shelf because you have more free radicals in there. The worst case is irradiated polyethylene stored in air. And that's what happened in the earlier ones. Murali Jassy showed that if you have these jumbo cups, size 72 jumbo cups sitting on the shelf for 5 or 6 years, and they're irradiated in air, and they sat on the shelf for 5 or 6 years, those bad boys wore out in 4 or 5 years because they're completely oxidized on the shelf. So you've got to be very careful about your shelf storage life, especially in what we call odd lot sizes, i.e. very small, very large cases. So again, you want to avoid long storage times. We recommend no more than 4 to 6 months. Your reps are going to go crazy with that statement. Be careful about the odd lot sizes. You've got to make sure you check the serial numbers and see how long they've been on the shelf. Remember, your reps won't always tell you that, right? So remember, the bottom line, going on away from metal polyethylene, no matter how you manufacture it, design it, sterilize it, package it, remember polyethylene is polyethylene. It's soft, and hard on soft is always going to wear. And that the cyclic motion will always generate polyethylene debris. And that's led us to move on to other solutions, which are hard on hard bearings, which are metal and ceramic on ceramic. And that's what you've seen in the last 5 years. Now remember, on hard bearing surfaces, the lubrication regimen is mixed. Part of the time it's hydrodynamic, i.e. fluid film lubrication, which is good, low resistance. Part of the time it's boundary lubrication. And the definition of hydrodynamic lubrication is that the joint bearing has to be moving all the time. That's why you can't have hydrodynamic lubrication all the time in the hip, because if you're sitting still and you're not moving, you're not having a fluid film lubrication. When it's moving, you can get fluid film. When you're at rest or moving around just a little bit, it's boundary lubrication. So it's mixed lubrication. Okay. You got to remember this, is that metal bearings, ceramic bearings do generate particles, but they're very, very small. And it is thought because these particles are so small, they elicit a less of an osteolytic reaction. And it is thought that particles 0.2 microns or above what cause osteolysis. Anything below 0.2 may not generate that osteolytic region as much. And what you need to remember is that these hard on hard bearing couples generate actually more absolute debris particles than the other bearings, the soft bearings, because they're so small you can't see them, but the absolute number is actually increased. What you do see, though, is very low linear wear rates and very low wear volumes, but the particles are so small the absolute number is actually higher. The parameters for successful bearing function of a hard on hard bearing is surface roughness and radial clearance and sphericity. These surface roughnesses of these hard on hard bearings are very, very smooth. You can see on the top they're 0.5 microns. In comparison, a red cell diameter is 7 microns, so you can see that these are highly polished surfaces. And that's what gives you that fluid film lubrication. The important thing you need to know for testing is radial clearance. Radial clearance is the difference between the radius of the cup and the stem. You have to have the optimum radial clearance because you've got to get some fluid in and you've got to get some fluid out to get that fluid film lubrication, and also to get the fluid removal. What we learned in the past is that if you look at the left, if you had a radial clearance which was too much of a difference, you had point loading, and you would have what we call polar contact and low conformity, high stress loads, and that would cause sliding wear and scratching and wear. On the far right, you would have what we call equatorial contact. The contact was at the equator. There was no fluid going in there, and these would seize up and it'd have a high frictional torque. But if you design it just right, that you have mid-polar contact, you have enough fluid to get in there to get your fluid film lubrication, and you had high conformity, you get good bearing wear. So what you need to know is mid-polar contact gives you the best wear profile. And this is just a graph showing that the wear rates, you start from equatorial contact where you have no fluid going in, and then you drop down to you have the optimum clearance, and then as you get to a higher radial clearance and a higher mismatch, you get sloppy wear, scratching. So the optimum clearance depends on the material and the head diameter, typically it's less than 150 microns. There's that rule of 150 to 150. Remember the MAC rules of 50s. Also remember that you want a very round head. Spherulites need to be kept less than 10 microns. These high points can cause stress concentration and cause increased friction. Those are the three things you need to know. There's also a phenomenon of what we call run-in wear. When you put these metal bearings in, it's just like a brand new car that's first 10,000 miles, or the hip, the first million cycles, you're going to get excessive wear until you rub those high points out. That is run-in wear. So you have high wear rate for the first million cycles, and then you reduce to a low steady state thereafter. And that's the definition of run-in wear with hard-on-hard bearing. It represents an in vivo polishing of the two round surfaces. You polish out basically the high points, and that's all you need to know about that. Remember that the hard-on-hard bearing, the debris, is very, very small, and with metal particles, you can ionize these into cobalt-chrome ions. So cobalt ions and chrome ions can get into the blood. There is sustained levels in the blood and in the urine. However, to this date, with the meta-analysis, which is shown by Smalsreed and Tarani, there has been no associated increased rate of neoplasia in any of the world studies with the meta-analysis. There's obviously going to be no cancer risk with ceramic debris because basically what you're wearing is dirt. Okay? So I'm going to go on to my next one, which is unstable total hip. Moving along here, finishing up the hip. This is a lecture on unstable hip, and it takes you through some of the parameters that I look at for evaluating this, and it gives us some pearls along the way for the test. The dislocated hip, the evaluation is often complex and multifactorial. It's seen up to 9.5% in primaries and up to 26% with multiple revisions. The highest rate of dislocation is in the elderly patient after fractures. Typical, I'll just move on to here. The typical highest incidence of dislocation is the elderly patient over 80 with failed osteosynthesis for femoral neck fractures, i.e. you put in a DHS screw, it cuts out, you convert it to a total hip. In Eklund's study in Europe, the dislocation rate was 82%. And that has to do with elderly debilitated patients with damaged soft tissues. So that's the key point you need to know there. The dislocated hip assessment, you have to look at design, you have to look at component alignment, you have to look at the soft tissue tensioning, and look at the soft tissue functioning. In terms of component design, it's the primary arc range that determines the extent of the stability of the hip. The factors affecting the primary arc range are head size, neck thickness, and modifications of the cup in the neck. The best way to show that to you is through some diagrams here. Remember that primary arc range is greater than with larger heads, and that with taper small necks have a greater arc range than, the arc range is greater with small necks. And here's how we go through this. I'm sorry it didn't come out well on the diagram, but this is a 180-degree acetabulum, 22-millimeter head, and a standard taper. And if you take this hip through a range of motion, you're going to have impingement, and that's going to impinge on the neck. And if you take it in both directions, what you're going to have is our primary arc range from impingement to impingement. So with a 22-millimeter head, standard taper, the arc range in this example is 100 degrees. Now, if you increase the head, and that's all you do in this system here, is increase the head size from 22 to 32 millimeters, you increase the primary arc range, you increase it by 20 degrees. Now, if you take it and take the 22-millimeter head and put in a narrow neck, and that's the only thing you've done here, you've also increased the primary arc range. In this example, it's 122 degrees. And what we want to prove here is that the main reason that you have these increases in range is that what we describe as the head-neck ratio. It's the head diameter to the neck diameter, which determines the primary arc range, and that's the test question. The range of motion of hip is directly related to the head-neck ratio. So basically, if you want to optimize your range of motion, you want a large head and a narrow neck. For example, here you have two examples increasing the head-neck ratio. Here you have the same head size, which is 28 millimeter head. One is a large fat neck, which is a 12-14 taper, and the one on the right is a narrow 3-degree included taper. Both hips taken through a range of motion. You can see the one on the top, the 12-14 taper, 115 degrees. The smaller narrow taper, 126 degrees. Another example, here you go, keeping the same neck, but you increase the head size. So you go from 28 to 32 to 38. You can see you can increase the range of motion greatly by just changing the head size. And what you're doing in both examples is optimizing the head-neck ratio, which is a large ball, narrow neck, gives you the best arc range, okay? Any modification is going to affect your range of motion. So cup and neck additions tend to diminish the primary arc range. So if you put a posterior hood and you think, oh, I'm going to make this hip more stable, in effect, you're really diminishing the primary arc range, and you're going to be a setup for instability in the other direction. So if you put a 20-degree posterior hood posteriorly, you're going to decrease your arc range from 100 degrees down to 80 degrees, and if you lever an external rotation, you're going to anteriorly dislocate. If you modify the neck where you put on, for example, a collar, you're going to make that neck thicker, you're going to change the head-neck ratio, and you're going to have a decreased arc of motion, and you're going to have more chance for dislocation. If you look here, if you modify it with a constrained liner is supposed to make your hip stable, but in actuality, you really diminish the arc range down to 60 degrees. And the problem is most patients don't like to live with an arc range of 60 degrees, and so they'll bump it in flexion and extension and then loosen the cup. And if the cup doesn't come loose, they'll break the polyethylene, and then it'll dislocate again. So what you need to understand in head-neck ratio is that collars for long necks decrease the primary arc range. So you don't want to use collars at all if you want to maintain a stable hip. It effectively increases the taper diameter and adversely affects the head-neck ratio. Augmented liners also decrease the primary arc range, and even though you think you're more stable, you're actually not. You've decreased the primary arc range. And constrained liners markedly decrease the primary arc range. The other thing you need to know about component design is excursion distance. That's the distance of levering. So once you reach primary impingement, then you start to lever. That's called excursion distance. So here's your 22 millimeter head. You start to lever, and it starts to travel that distance. That distance between those two dots is your excursion distance. And then it starts, once it levers up past that point, then it dislocates. So with a 22 millimeter head, it takes 11 millimeters of excursion to come out of socket. A 38 millimeter head will take 19 millimeters to lever out. So that excursion distance is better with larger heads, and that's why larger heads are more stable. So two reasons for stability of large balls: head-neck ratio and also excursion distance. So a large head has a large excursion distance and is more stable, so therefore the most stable hip is a bipolar or monopolar head of the same size that you removed. That's why you have someone that's old. We put in bipolars or monopolars because these patients are demented and they're going to dislocate and they're not going to be very active, so we don't have to do the total hip. But that's the reason you use these bipolar heads, because they're stable as a rock. The other thing you need to know is alignment. You need to know your acetabular version, your acetabular tip, and your femoral anteversion. Remember that a malaligned component does not decrease the primary arc range. It just does not correspond to the patient's functional range, and the result is an increased excursion in one of these directions. This means a higher chance of dislocation, and you'll say, what did he just say? And it's hard to show that without showing this example. If you know that the arc range of a large ball is going to give you a large range. So the native hip is going to have the highest, the native acetabulum and head is going to have the highest arc range. And then anything less than that, i.e. your total hip, is going to have a less of a primary arc range. So what you want to do here is that the patient's functional range is in the yellow. The arc range of your total hip, which is less, is in the blue. You want to center that primary arc range within the middle of that patient's hip range, functional hip range. And then if they get to the extremes of the hip range, then you have your excursion distance to kind of keep you stable there. If you malalign the components, you don't change the arc range, you just put it over to one side. So on one side, for example, if you retrovert the cup, if you flex it, you're going to be very unstable. If you externally rotate it, you're going to be stable as a rock. My point here is that the primary arc range, if you center it right, you're going to be stable. You center it to one side. In one direction, you're going to be stable as rock. The other one, you're going to be unstable. So that's why component alignment is just as important as the primary arc range. So what happens is that the red dots where you have primary impingement, then you have that excursion distance. So in this direction where your excursion distance ends, that's your dislocation range right there, in that area right there. Remember green laser? Remember style points there, right? Okay. Component alignment, basically we want our acetabular anteversion to be about 20 to 30 degrees. That mimics what we have in the native acetabulum. This is an example of a revision that I did. This cup anteversion is too high. You run the risk of anterior dislocation. You want to reorient that down to the corrected anteversion of 20 to 30 degrees. Okay. Also, you want to avoid a retroverted cup. If you have a retroverted cup where those red arrows are, you're going to run the risk of posterior dislocation with a retroverted cup. So you have an anteverted cup, you're going to have anterior dislocation. If you have a retroverted cup, you're going to have posterior dislocation. And then you want your theta angle, which is your acetabular tilt, to be about 35 to 40 degrees. A low theta angle means you're going to have trochanteric impingement, and you're going to have levering out either anterior or posteriorly. A high theta angle gives you those superior posterior dislocations, okay? So avoid high theta angles, avoid low theta angles. Okay. Femoral anteversion should be around 10 to 15 degrees. For normal anatomy, the prosthetic neck should line up on the same axis as the femoral neck, which is around 10 to 15 degrees. Anteversion runs a risk, excess of anteversion runs a risk of dislocation, and so you want to mate your anteversion correct. So if you have a retroverted stem, you run the risk of posterior dislocation, because what happens is the trochanter tends to hit first and then you start to lever. So a retroverted stem, you run the risk of posterior dislocation. Okay? In terms of component alignment, interoperative trialing is important. You must take the hip to the extremes of motion and anticipated patient positions. This is where you check the patient's hip range, or i.e. the total hip range to the patient's functional range, i.e. you want to center that total hip range within the middle of the patient's functional range. And that's what you're doing with this exercise. So in terms of positioning, you can say, well, positioning is great, but remember, it's the muscles that keep the hip in place. The abductor complex is the key to hip stability. Remember that abductor complex is the gluteus medius and minimus. That was an in-training question. If I think one of the residents told me, that was a board question. I'm not supposed to tell you that, by the way. Nobody's supposed to tell me board questions, right? That's all illegal. I guess, oh crap, I'm on tape too. Oh. Remember, abductor complex, the key to stability. Gluteus medius and gluteus minimus. Pre-op planning, you want to measure your head offset and you want to measure your neck length, because what you want to do is you want to restore the head offset and you want to restore the neck length to the same position that you were before. The reason being is you want to put that abductor complex on tension. So when you put these templates on there, you want to restore the center of the head, you want to restore the offset and the neck length. And the reason for doing all of that is to give you hip stability with the abductor complex. So here's my options here. In this one, I chose a lateral offset design because that most closely represented the center of head, which most closely recreated the offset from the head to the trochanter, and most closely represented the neck length. And if you do that, you have restoration of abductor tension. So you reestablish normal hip center rotation with a restored head offset and a restored neck length. And that's the basic reason of why we do our templating, is the abductor complex is the key to keeping that hip stable. So with restored hip mechanics, you have normal abductor power, normal hip compression, and normal hip stability. The problems are with shortened hip lengths, where you have a weakened abductor complex, the soft tissues are not as strong, the trochanter impinges, and then you get instability. So if you're one of those guys that says, oh, you just cut a thumb breadth below or above your lesser trochanter, if you have a real long neck and you just do that every single time, every once in a while you're going to get your butt burned, because your neck is going to be short, your abductors are going to be soft, and you're going to impinge. So that's why templating is real important. So with a low neck cut and a short head, the abductor complex is weak. You have diminished offset, and you have a risk for dislocation. What will happen is you abduct, you have the trochanteric impingement, and you have a weak abductor complex giving you instability. Now, The biggest problem is the low neck cut and the short head and a narrow offset, like I did in this case. And this is my case. I admit it myself. This is one I really screwed up on. And you get secondary impingement, a weak abductor complex, and instability. And there's not much you can do about this one when you have a narrow offset. You have to take that stem out and start over. That was the wrong stem design for this patient. And what you need to know is that offset and neck length are very important, that not all stems match everybody's anatomy, and that sometimes you have to use another implant. Well, you say, well, I cut low. I'll tell you what I'll do. That's not a big deal. I'll just put a long neck on it. Well, you can do that. The problem is with a long head, guess what you've done? You've put on a thick collar on your neck. You've just changed your head-neck ratio. You've adversely affected your head-neck ratio, and even though you restored your tension, you lever up, you're going to cause a diminished primary arc range, and you're going to dislocate. So that's why I don't want to use any collars on my necks. So a low neck cut with a restored length. Another problem is that you can push out the trochanter far, and you increase the offset, and you can get trochanteric bursitis and pain. A soft tissue tension problem also is seen with trochanteric escape, which is a tough problem. That's why I tend not to use trochanteric osteotomies. Remember that the standard approach with a trochanteric osteotomy, the non-union rate is anywhere between 10 and 15%. If you lose the trochanter, then you have trochanteric escape. That's a tough problem. You have loss of that hip compression. So you lose that hip compression, and you have a higher risk for instability. And those x-rays, by the way, those are mine. Thank you very much. The solutions for trochanteric escape, you can debride the trochanter so it doesn't get in the way and doesn't cause impingement. You can optimize the head-neck ratio, i.e. you go to a larger ball and you take out the hoods and you take out the collars if you can. You change it to a hemisphere polyethylene insert, i.e. no posterior hoods, and maximize that head-neck ratio as much as you can. So in this particular case, you had trochanteric escape. I debrided the trochanter. I went to a larger head, and I couldn't do it. And then the last choice here, you can go to a constrained liner. The problem with a constrained liner is you have a very limited arc range, and that even though it's stable, the patient, if they're not going to comply with that limited arc range, are going to lever, and either the cup's going to come loose or the constrained liner is going to break. In terms of soft tissue function, you've got to remember that the nerves and muscles are an important factor. Central nervous system, peripheral nervous system, and local soft tissues all play a role. Just remember that if you have any effect in the central peripheral nervous system, you're going to have local muscle dysfunction causing dislocation. Got to remember the central issues of stroke, cerebellar dysfunction, psychiatric disorders, i.e. drug addiction, dislocating your hip on purpose to get drugs, dementia, delirium. CNS dysfunction causes abductor dysfunction, causing impaired coordination, and you lose your precautions. Also remember your peripheral issues of paralysis, paresis, spasticity, myopathy, all affect your hip stability. Also remember the peripheral nervous system, spinal stenosis can cause hip stability because your abductor complex may be affected by the peripheral nervous system, causing deconditioning and weakness. And what I could see on a test question would be, they hit you, a patient with spinal stenosis is very debilitated. They're going to maybe make you think about head-neck ratios. They're going to think about maybe larger balls. So that's how I would interpret some of those test questions. Okay? Remember that local tissues can be damaged as well from tumor and radiation and dysplasia. Remember that dysplasia of a hip not only is dysplasia of the bone, but dysplasia of the muscles and the surrounding support ligaments that are not as well developed, and there's a higher rate of dislocation with dysplastic hips. Here's an example of dislocation here, a 52-year-old with massive osteolysis. It all fell apart. The trochanter was in pieces. I resected the trochanter, and what I wanted to show here is because the trochanter is missing, I used a large 38-millimeter ball and preserved the abductor sleeve, and that was a way of maximizing the head-neck ratio, and I did not want to go to a constrained liner. Remember, with the dislocated hip, there's not going to be one solution that works for every case. You've got to look at component design, alignment, tension, function, what we just talked about. You've got to look at the x-rays, and you also got to look at the dislocating event. Was the patient in a normal position when it dislocated, or did they take it through the extremes? You've got to look at the cognitive function. The patient had a stroke, or are they not going to listen to your precautions later on because they're demented? You've got to look at those x-rays. You look at the intraoperative assessment of the hip stability on the table. Remember that 2/3 of patients with a dislocated hip can be treated successfully with closed maneuvers. So the first thing you do with a dislocated hip the first time, closed reduction and put them in a brace. So you educate the patient. You can use a spica cast or a spica brace. Those are the two that I've used. Some people use a neomobilizer because most people can't lift the leg high enough with a neomobilizer to put it in a position to dislocate, but I tend to use the spica braces. In the old days, you used to put them in traction, but nobody does that anymore, at least in the United States. So in terms of closed reduction, what you need to know is you take the hip through the full range of motion, just like we did when you did your total hip. If they put them through the functional range and they dislocate with 0 degrees of rotation, you know you got to revise it. You know you have component malalignment. The options are component revision, trochanteric advancement, conversion to a bipolar or monopolar. Remember, treatment, if your parts are malaligned, you got to revise it. No way out, no way around it. If the components are aligned and the soft tissues are stretched out, sometimes a trochanteric advancement is the way to go. And if you're still dislocating, then you go to that increased head-neck ratio, convert it to a bipolar or monopolar, because that's the best way to enhance the stability. The other options are going to a tripolar, which we'll talk about, which maximizes a head-neck ratio. You can convert to a constrained polyethylene insert, but that is a last resort because you have a high rate of mechanical loosening of the cup and the liner, and if things are really bad, you can resect it. Remember that if the parts are malaligned, you got to change it. So if you have a case where you have excess of aversion and you got recurrent anterior dislocation, you got to revise the parts. And if the parts are well fixed, it can be an arduous task, but you still got to do it. You can't go any other way. So remember that parts are malaligned, you got to revise it. However, and I've seen this on test questions, if the parts are well aligned and your abductor complex is a little bit short, instead of revising the parts, you can do a trochanteric advancement, and that basically is akin to the old Charnley tensioning. Charnley did a trochanteric osteotomy not only for exposure, but for stability of the hip. Sometimes he would take that trochanter and pull it down to make the soft tissues tighter, and nobody talks about that very much, but if you read the original book, i.e. the Bible, that Charnley would bring that down and tension that greater trochanter to give you that stability. So the test questions I saw last year and a couple of years ago is a hip that is got normal alignment, recurrent dislocator, the option is trochanteric advancement, i.e. Charnley tensioning. You tension the abductor complex, bring it down and cable it down to stabilize it. The indications are no component malalignment. If you have something that's malaligned, it doesn't matter how tight you make the hip. If you lever it, you're going to lever out. You've got to have adequate bone surface for the distal advancement. So if you have osteolysis and you have no bone for that bone to stick to, you can't do the advancement. That makes intuitive sense. The principles going on to bipolar or monopolar conversion, you got to remember that you can't just switch to a bipolar head without having adequate acetabular bone. If you don't have enough bone, i.e. you don't have a rim seated on, it's going to dislocate. So when you do a bipolar conversion, it's sometimes hard because you've got to take out a well-fixed acetabular cup, which you could lose bone. What you've got to do is you've got to fit the bipolar or the monopolar on the bone like a non-cemented cup. Otherwise, if you put it in there loose, it's going to toggle and it's going to migrate into the pelvis. So the technique is a rim fit of the bipolar. And when I say rim fit, I just want you to, if you have the rim measuring 55, you put in a 55 millimeter bipolar. You don't put in a 53 and let it slop around in there. Okay. Bipolar conversion, Rice and Weidel showed that there was no component migration if you sat it on the rim. The problem is with bipolar conversion on bone is you got groin pain. Hence, that was the problem of going to a tripolar, and a tripolar is basically a bipolar in a large acetabular jumbo cup. So what they would do is they would overream the acetabular cup, put it in with screws, and then put a bipolar into this large cup. And that would increase your head-neck ratio and give you stability, and that resolves the problem of bipolar or monopolar groin pain. So here's an example of a tripolar. So you have a large jumbo acetabular cup, and then inside that you put a large polyethylene socket, and then you put a bipolar on top of that so that you have a double motion. You've optimized your head-neck ratio, and you get hip stability. The problem with that, as you would think, is thin polyethylene cups high volumetric wear. Remember the volumetric wear thing that we're talking about? Particle debris generation related to the head. So if you're going to get stability, these patients better not be very active, because I tell you, they're going to get a lot of osteolysis real quick. And that's a trade-off. But I tell you, being called 2:30 in the morning with hip dislocation is a lot better than seeing these patients in the clinic with osteolysis. Anyway, dislocations are also seen with tripolar or bipolar can still dislocate if you have weak abductors. So if your abductors are paralyzed, these big bipolar balls can still dislocate, which leads to the constrained polyethylene insert. These are reserved for the multiple dislocator with soft tissue dysfunction. If your abductors are not working, then you can use the constrained inserts. Remember, you're going to have rapid polyethylene failure, i.e. mechanical failure, if you're not compliant with the range of motion, because they're going to lever on that end and break it. The failure mechanism depends on the design. If the polyethylene insert deforms at the edges, then you're going to get plastic deformation and the cup's going to dislocate, i.e. the head's going to dislocate. But if your polyethylene insert is rock solid design, then the acetabular is going to come loose at the bone interface and you're going to get cup loosening at the bone. So that just really depends on the design. So in summary, the dislocated hip assessment treatment is complex. Each case is unique. You want to select the appropriate solution for the particular circumstances. Remember that hip compression, hip stability are directly related to the abductor complex. That pre-op templating is important. You want to restore the offset and neck length. You ought to understand your tapers, your collars, your hood designs. You've got to understand your head-neck ratio. You want to optimize that head-neck ratio. You also want to put your parts within the middle of the patient's functional range and don't have any excess of excursion. So that's why you've got to understand everything in terms of the design. Here's one case of a patient that was sent to me with a recurrent dislocator. Primary hip, it got a periprosthetic fracture. They cemented in a long stem all the way to the knee, well fixed, but components were malaligned. This had to be treated with an extended trochanteric osteotomy to the knee, a custom cup, trochanteric advancement. The point being is that you have to do everything that you need to provide the stability that you need for the hip. So anyway, I'm done with that. I've got a couple more minutes, so I'm going to go on to knees because I have 3 of the knees to go. Okay, continuing on the Mark's Review course, we're going to go on to total knee replacements. I'll stop at 12:15, and that'll give me enough time for tomorrow to finish up. We're going to talk about technical aspects of reconstruction and prosthetic design in total knees. A lot of things that you got to think about in terms of total knee replacement. So we're going to go through these in a step-by-step process. Running a little slow on the computer. In terms of the technical aspects of total knee, what we want to go through is pre-op planning. We want to talk about component insertion, ligament balancing, which is important for the test, and prosthetic design and selection and indications, which is also important for the test. The technical goals of knee replacement surgery, number 1 is you want to restore the mechanical alignment. It's not the anatomical alignment. We want to restore the mechanical alignment. Center of hip, center knee, center ankle. You'll want to restore the joint line. The other thing is you want balanced ligaments, and you want to have a normal Q angle. If you do those 4 things, you've done a good job. Prosthesis is going to last a long time. Consistent clinical results are predicated on good preoperative planning. If you don't plan well, you're going to feel like this slide at the end of the case. Okay? All right. Starting off with the arthritis series, you want a standing full length of both x-rays because you want to make sure that ligaments aren't severely damaged. You don't have any excessive varus or bowing or valgus bowing. You want to see if there's any proximal distal deformities. You want to see extension and flexion laterals. You want to see your sunrise for your kneecap. Example here, this is a patient with knee pain who was in another clinic and got weight-bearing x-rays. The x-rays on the right are the same patient 7 days later with a standing arthritis series, and you can see there's a big difference in how those knees look like just with standing on that. And if you want the best sensitive test for arthritis is a single leg stance AP for the knee. What you want to do in pre-op assessment is you want to assess the valgus angle of the femoral component, you want to look at bone cuts, and you want to look at and anticipate the ligament releases that you got to do. Weight-bearing x-rays are good for the extent of joint space narrowing, ligament stretch out, and you want to see if there's any subluxations. For example, here, this is a really nice example because it's going to prepare me. This is a patient, single leg stance x-rays show dramatic stretch out of that lateral ligament complex. Had I not done those single leg stances, you would have said, well, I would have come into that x-ray with, or that case with just a standard prosthesis, and if I didn't have my revision constrained components there, I would have been SOL because there is no way I was going to make that knee stable without some big, large post in the middle. So a single leg stance is the most sensitive x-ray to assess for arthritis and ligament instability. Full-length x-rays are key when you want to look at femoral tibial deformities. Somebody's very tall or very short. And the reason is that we've got to assess the valgus cut angles. What we are looking at the radiographic analysis is the anatomic axis of the femur, which is a line that bisects the medullary canal of the femur, and that determines the entry point of the medullary guide rod. If you look here, if we draw the green line on the femur as the anatomic axis, you start it and it bisects the femoral shaft. It comes out distally, and that tells us where our medullary entry point is going to be for the jigs. What we want to do is recreate the mechanical alignment, which is the center of head to the center of the ankle, and that's that red line. And the difference between the green line and the red line is the valgus cut angle, because what we want to do is our medullary jig goes in the bone, and what we want at the end is the prosthesis pointing towards the center of the head. So the valgus cut angle is that angle, and if you measure that, that's what you're going to dial in the OR. So I always do my full-length radiographs and dial it in. And so your distal femoral cut, whether it's 4, 5, 6, 7, 8, or 9 degrees, is determined by this valgus cut angle, and that's how you dial in that number. So the mechanical axis of the femur is aligned from the center of head to the center of the distal femur, and that cut is made perpendicular to the mechanical axis. So in terms of pre-op planning, the distal femoral cut is perpendicular to the mechanical axis of the femur. Now the important thing to know is most of the time if you dialed in 6 degrees, for 90% of the patients you're going to be dead on, because the valgus cut angle on average is between 5 and 7 degrees, and cuts are usually with 1 degree of error. So if you dial in 6, you're going to be in the middle. The problem is somebody's real short or somebody's real tall. If you dial in, say, 7 degrees, normally on all your patients you have somebody that's 6'9", their leg is, if you dial in 7 degrees on somebody that's 6'9", their leg's going to be pointing towards New Jersey. You know, so somebody who's real tall, the valgus cut angle is going to be low. It's going to be like 4 degrees, sometimes 3 degrees. Conversely, if somebody's real short, i.e. 4'9" or 4'8", the valgus cut angle is going to be a lot larger. It's going to be 8 degrees. So the valgus cut angle is important in the extremes, very tall, very short. So if you have somebody at middle range, you don't need to do the full length. I do it at my institution for teaching, but if you're in private practice, somebody who is real tall, real short, that's when you need the full length. You want to measure those valgus cut angles, and that's the reason for doing that. And so what you want to do is you want to do these pre-op measurements. The x-ray on the left is a full length. I've just taken a picture to show you what I do. I want that prosthesis pointing towards the hip center, and what you want to do on the right is avoid the one on the right. You don't want it pointing towards the other hip center. Okay? Simple stuff. And your jigs tell you that. So you put that distal femoral cutting block in, the valgus cut angle guide is right there, and you dial in whatever degrees you want, and that medullary rod is in there. And the goal is the prosthesis pointing towards the center of the head. On the tibial side, you want the anatomic axis of the tibia to be measured, and that's the line that bisects the medullary canal of the tibia. It determines the entry point of the tibial medullary guide rod. Sometimes they're off to the side a little bit. The mechanical axis is a line from the center of the proximal tibia to the center of the ankle, and the proximal tibia is cut perpendicular to the mechanical axis, not to the anatomic axis. It just so happens that in a tibia, the anatomic axis and mechanical axis are always coincident, except if you've had fractures or other deformities. So the tibial cut is made perpendicular to the mechanical axis. It just so happens that the anatomic axis and mechanical axis do line up a majority of the time. The case is here is where they're divergent, i.e. a tibia fracture. You don't want to put a medullary rod in the proximal tibia and dial in perpendicular because it's not going to point towards the ankle. What you want to understand is that your parts are going to be cut perpendicular to the mechanical axis down to the ankle. And in this case, what you want to do is put on an extramedullary jig and point that jig towards the center of the ankle, because that's where you want it. And that's the key that you need to learn about pre-op templating. The other thing is that when you're doing your templating, you want to look at bone defects, because you want to make sure you need to order the appropriate parts. If you do your templating and you see that you have a bone defect, you're going to be prepared to fill it in with screws, or if you need to, call in your revision system to fix it. Same thing on the valgus deformities. I always see a lot of valgus defects on these valgus deformities over 15 degrees. So I'm going to be templating, and if I see a defect like I see right here on this x-ray, I'm going to be making sure that I have medullary stems and rectangular augmentation blocks for my replacements. In terms of the bone cuts, remember that the goal of your bone cuts is to replace the bone and cartilage that you cut off with a prosthesis of the same thickness. This will maintain the joint line and maintain the appropriate ligament tension. So what you're doing with all these jigs is putting on the same size parts that you took off. That maintains the thickness and maintains ligament tension. So what you're doing with these jigs is that you're aligning it to confirm your mechanical axis, then you're cutting it off and measuring what you cut off, and then replacing it with something of the same thickness. Hence, that's why we've gone through all these instrumentations to make things better. You must restore bone defects to allow the cap to assume a normal anatomic position. That sounds real intuitive, but if you have a defect here, like you see in the upper left there, and you have that defect, and you put the parts on to, like you see in that red line, you're going to have an externally rotated component, and you're going to have patellofemoral malalignment, and you're going to have a bad problem. Instead, what you want to do is recognize your defects, fill them up so you can restore the normal rotation of the component. So you restore it with either metallic wedges or cement and screws. You want to never rely solely on your instruments. You always want to check and double check your cuts. So you make the cuts with your jigs. You check them with these long rods to make sure that you got the appropriate cuts, because a malaligned component is the most common reason for instability. You always want to protect the collateral ligaments when using the saw. This is not necessarily a bone question. This is a common sense thing for you, because if you don't protect them, you can have a case like this where I can tell you it only takes about 3 seconds for a collateral ligament to be cut. And I can tell you 2 days ago we had a PCL cut. And just the saw went straight through and cut the PCL, and boom, it's gone, 2 seconds. So what you want to do is you want to protect your collateral ligaments, and you don't want to have a case like you have here. All right. Got to maintain a normal Q angle. So you want to avoid techniques that result in an increased Q angle. Remember, the Q angle is the line of the extension mechanism to the line of patella tendon. So it's not basically an anatomic thing or an anatomic landmark. It is the center of the quadricep tendon to the center of the kneecap, and then from the center of the kneecap to the center of the tibial tubercle. And what you want to do is maintain a normal Q angle. In terms of the complications of total knee, the most common complication in total knee replacement involves abnormal patellofemoral maltracking. Patellofemoral joint is the most common problem associated with knee replacement surgery. Now it's a test question. If you have an increased Q angle, then you have increased subluxation forces laterally, you have lateral tilt, you have lateral tracking, you have anterior knee pain, you have patellofemoral crunching, and you have pain. The next step is ligament balancing in total knees. There are 2 different planes to address in a total knee. There's the coronal plane, which is varus valgus, and then sagittal plane, which is flexion and extension. And there's always great questions on flexion and extension, i.e. Balancing the gaps. And we'll go through this for a couple minutes. I'm going to stop right at 12:15 and pick this up tomorrow. We'll go through coronal plane balancing. Remember that the principle here is you want to release on the concave side of the deformity and you want to tighten on the convex side. So the principle here is, it doesn't matter whether it's varus or valgus, on the concave side the ligaments are tight and contracted, and on the convex side the ligaments are stretched out and loose. You do not want to do your approach over the convex side, and you don't want to touch that lateral or the convex side, because any tampering with that area is going to stretch it out even further. So what you want to do is do all your releases on the concave side so you fill up the gap and make it equal to the convex side. So in terms of a varus deformity, what you want to do is the concave side is the medial side. You want to do a medial release. You want to fill up the lateral side until the lateral collateral ligament is tight. So in a varus deformity, the convex side is the lateral side, the concave side is the medial side, and you're going to do a medial release to swing that leg around and balance the ligaments, knowing that you've just already made your bone cuts perpendicular to mechanical axis, right? Right. So your medial release, the first thing you do is you start off with your osteophytes. That's the first thing you do. The second thing in the order is deep medial collateral ligament. The deep medial collateral ligament is also called the meniscal tibial ligament. It's right next to the capsule, and that's the slide on the bottom there. You release that if you need to. After that, you go to the posterior medial corner and release it to improve your release. And then the last thing you release is the superficial medial collateral ligament, also known as the pes anserine complex. Say grace before T, right? Right. And that's the order of releases. So here, the deep medial collateral ligament is right below the capsule on that arrow. The superficial collateral ligament is down further. So this is the deep, right underneath the joint line. This is the superficial, right in this area. And what you want to release is that pes all the way down into here. And that's the last thing you release. And then you got to be really careful. If you have a really bad varus deformity and you release that pes 5-6 centimeters below, you got 1 centimeter left. If you stress it, it pops. That's it. It's all gone. And if you do a complete release of the superficial medial collateral ligament, what do you got to do? You got to go to a constrained post. How often do I do that? More often than not. That happens. But what you got to understand is, if you mess up, that's okay. Just understand, I got a big varus knee. I got to be prepared with this prosthesis, and my backup is B. This is plan B. So the superficial medial collateral ligament blends with the pes anserine complex. Pes anserine is the semitendinosus and gracilis and sartorius. And that's down on the lower part of the tibia. And it extends way down on the tibia, several centimeters way down, almost to the proximal diaphysis, proximal third of the diaphysis. Okay? Valgus deformities. Same idea. You release on the convex side, and you don't do anything on the concave side. Or you release the concave side, excuse me. So on this, what you're doing is a careful release of the lateral side. When I say a careful release, remember that the perineal nerve is behind the fibular head. And you want to fill up the medial side until the medial collateral ligament is tight, and you want to be careful of the perineal nerve. In training, question, board question, correction of the valgus flexion deformity is the highest risk for perineal nerve palsy. If you see a test question that says valgus deformity, flexion contracture, and valgus flexion, the biggest deformity that causes the highest rate of perineal nerve palsy is valgus flexion. If you don't see valgus flexion, the next one that's most prominent for perineal nerve palsy is valgus deformity. What do you do if you have a perineal nerve palsy post-op after total knee? Number one thing you do is what? Take off the compression dressing and bend the knee and relax the nerve, okay? Valgus deformities, here we go. The convex side, the stretched out side, is the medial side. The concave side is the contracted side, and it's a lateral release is required. So on the lateral side, again, you release the osteophytes, you release the capsule. The other options that you need to think about are iliotibial band and popliteus. The lateral collateral ligament should be the last structure to be released. Here's the great test question. It was on in training last year, probably will be on the boards. Remember this pearl, that valgus deformity correction on the lateral side. The iliotibial band is tight in extension. The popliteus is tight in flexion. So they'll say you're balancing your knee is okay in extension, but when you flex your knee, you're tight. So what you want to do is release the popliteus. If, on the other hand, you're in flexion, your balance in the coronal plane is good, and then you bring in an extension that pulls into valgus, the thing you want to release is iliotibial band. That was on the in-training last year. That's a great board question because that's the asymmetry. I would definitely remember that. That's a little pearl. Remember also the popliteal tendon inserts onto the lateral epicondyle just in front of, which is distal and anterior to the lateral caudal ligament. So you can release it up in that area. That was a test question 2 or 3 years ago. So that's the location of the popliteus. It's a distal and anterior to the lateral caudal ligament on the lateral epicondyle. Well, in terms of flexion contracture, what you want to release is the posterior capsule. That's why it's very careful there, no plunge skis, because right behind there is the popliteal artery and peroneal nerve. You want to release that flexion contraction until you have full extension, okay? So again, flexion contraction you want to release on the concave side, and that would be a release of the posterior capsule. So if you have a flexion contraction, the first thing you think about, again, if you're on your oral boards, written boards, always release the osteophytes. The next thing is the posterior capsule. And if you have a real bad, severe flexion contraction, the next thing you release is the gastroc complex. And that releases the medial gastroc and lateral gastroc. And you've got to curve that osteotome, curve that curve cob elevator right underneath and then release it. And you've got to have good visualization to do that. So here's an example. The first thing you do is release the osteophytes in the capsule. And you do that with an elevator. And then again, this is the complications of total knee. The deformity most likely to cause palsy, valgus flexion together. Peroneal nerve palsy, when seen, the first treatment is to take off the compressive wraps and flex the knee. If the nerve is not cut, most palsies will resolve within 3 months. Krakow has shown that if you explore the nerve early, that there's a good chance of return. So if after 3 months you don't see any return of the peroneal nerve and your EMG shows that you didn't cut it, then there's a good indication to open it, explore it, and decompress it. And that was a study shown by Ken Krakow out of Buffalo. And I think I'm going to stop there because balancing the gaps is something that we'll take on tomorrow. So I know I was talking fast, but thank you. Appreciate your time.